again. So this is my second presentation for today. Before I start my presentation, I just want to highlight that I have another role. I'm lead for international fellowship programs in pediatrics and pediatric rheumatology for my region, northwest of England. So if you have any enthusiastic trainees, you can put them in touch with me, and we can offer them clinical attachments as well as further postgraduate diplomas and MS programs in pediatric rheumatology. So moving on to my presentation, I'm going to talk about major rheumatological diseases with dermatological overlap. In the interest of time, I'll keep it limited to two conditions only. So the first one, I'm sure all of you are familiar with juvenile systemic lupus erythematosus. A lot of people consider lupus in children and adults almost similar, but there's a huge drive in the international world to differentiate SLE from juvenile SLE. We know that juvenile SLE is extremely aggressive. It takes significant long time to improve, and prognosis is usually very good with right treatment. However, it can be fatal if it's not treated promptly. And again, girls more than boys, and incidence is less than 1 per 100,000 children per year. The incidence is much more higher in African and Asian population, and not only the incidence is higher in Asian and African population, it's also very aggressive and usually doesn't respond to first or second line treatment in Asian and African descent. And as you can see, lupus involves almost every part of the body, from your hair to your tip toes. However, the problem in lupus symptoms, that more than 95% of children with lupus present to primary care and secondary care multiple times with only one symptom, and that's tiredness and fatigue. Now you can imagine a teenager coming to your clinics and complaining of tiredness or fatigue, how much weight and how much attention you can pay to that. And usually at that point, the blood investigations are more or less normal. And I'll come to that investigation in a minute. So a lot of people call lupus as the greatest mimic. Lupus can mimic with almost any condition in the body. We still don't know why people get lupus, but we know that half of the children who get JSLE usually have a family history of autoimmunity. We don't know exactly why some children get monophasic lupus, why some get polyphasic lupus, but we know that there is element of genetics, hormones, and environment. So you see there's three peaks of lupus patients. Usually it's around the puberty time with the hormonal involvement, and flare-ups is almost always when there is a hormonal change in the body, like pregnancy, breastfeeding, or stressful events in the life, which can be physiological and pathological, such as infections, fractures, accidents, as well as simple as just moving your house or moving from a college to university. So I don't want to bore you with the long list of symptoms of lupus, but you can see that a lot of these symptoms can be presented in any systemic condition. And what is obviously much more relevant to most of my colleagues here is this mucocutaneous section. So the point is not working, but you can see the malar erythema, discoid lesions, mucosal ulceration, alopecia, and photosensitive skin. As I said earlier in my previous talk, that a lot of time these patients present with skin manifestations much earlier than they present with systemic manifestations. So it then becomes hugely, the role of dermatologist becomes hugely important to identify that this is not a simple rash, this is not just a butterfly rash, it's got more systemic signs. And sometimes a question as simple as, do you have joint pains? Do you feel tired all the time? Do you feel achy in the morning? These simple questions can help you to differentiate that it's not just a simple rash. And when it comes to examination, you can see these pictures with the malar rash, oral ulceration, and discoid lesions. Again, discoid lesions is something that our dermatology colleagues deal with much more and have much more experience than us. A lot of time, if discoid lesion does not have any systemic involvement, we just treat them with topical treatments. Again, there are lots of other symptoms. You can get rashes very similar to systemic vasculitis, such as livedo reticularis. Primary Raynaud's disease is very, very common in lupus patients, and almost 97% of lupus patients have ANA positivity, and more than 90% of lupus patients have Raynaud's as well. A lot of lupus patients have alopecia, and sometimes you need to be as specific as asking about whether they're losing hair from their eyebrows and eyelashes, because it may not be a prominent area such as scalp. Again, there's a long list of signs that you can come across with the lupus, but the idea of showing you so many signs of lupus is that you can potentially put these signs and symptoms and get any systemic disease with these signs and symptoms. So that's what makes lupus very unique, because it's got something out of a lot of systemic inflammatory conditions. Again, you can see a lot of mucocutaneous findings and vasculitic rashes involved with the lupus, but the most important finding not to miss are the renal and neurological findings. Now, in terms of investigations, again, it's a very long list, but I only want to point out to the couple of investigations. So lupus you can see from the blood profile that lupus can easily mimic with malignancy. You can see in lupus, all the counts are on the downside, and because a lot of lupus patients hemolyze as well, so they're usually DCT positive as well. But the most important blood test in terms of lupus is the reversal of the inflammatory markers. CRP is often normal in lupus patients with very, very high ESR. So always question, if you have CRP and ESR very high, could it be a lupus? Again, in terms of autoantibodies, I would think 100 times if a lupus patient has ANA negativity. But there's one investigation that you need to check. If you have a lupus patient with ANA negativity, that's anti-C1q antibodies, because anti-C1q antibody positivity will present as a systemic lupus, but will not have ANA or ENA positivity. In terms of other investigation, because it's a systemic inflammatory condition, so you had to come out of the box and look for all the findings. So usually multi-system investigations, so chest X-ray to look for serositis, such as pleural effusion, ECG for pericarditis, echocardiogram for pericardial effusions, and bone marrow aspirate to exclude the malignancy. Renal biopsy is wherever you have significant proteinuria and elevated albumin-creatinine ratio, renal biopsy is a mandatory to classify for the lupus nephritis, which helps not only for diagnosis, but it also guides the treatment. And when there is neurological involvement, always consider LP and MRI. It's important to check the immunity status to varicella and measles, because ultimately all these patients will be on very strong immunosuppression, so you don't want, if possible, you would like them to have live vaccinations before you start them on systemic immunosuppression. So in terms of diagnosis, and this is not really a diagnostic criteria, but we use ACR and SLIC criteria for the classification of lupus, and it can also guide you to diagnose systemic lupus as well. So you can see that this is quite an old criteria, but it's still very relevant and has been used in lots of studies. But you have to have 4 or more features to indicate lupus. However, more recently, we're using SLIC criteria for the last 10 years, and SLIC criteria is much more robust, and where you can use both the clinical and immunological features, as well as there's a role of biopsy as well. And there is a new criteria, the revised SLIC criteria, coming out next year, which will replace the SLIC criteria. After making the diagnosis, obviously the aim is to start treatment as promptly as possible. In any condition in medicine, the aim of treatment should always be to get to the remission as quickly as possible with as little medicine as possible. You don't want to produce toxicity, but you should not be afraid of using any medicine to get to the remission, because once you get to the remission with systemic inflammatory condition, and whether it's lupus or psoriatic arthritis or vasculitis, once you get to the remission as quickly as possible, the prognosis of the disease is going to be excellent. But if you worry too much about using stronger immunosuppression, then it's always going to be difficult. And once you have remission, then every time you see the patient, aim should really be, so if there's, for all the trainees, when you see somebody on the ward round or in your clinics, you should always be looking for what can I stop? What does this patient does not need now? So always look for minimum possible treatment to get maximum remission. In case of lupus, you need early aggressive immunosuppression, and that turns the corner around. So all the lupus patients, especially the ones with skin involvement, should go on hydroxychloroquine. Anyone on hydroxychloroquine should have a pre-hydroxychloroquine eye check, and then eye check after every 5 years. Hydroxychloroquine is safe in pregnancy, and it should be continued in pregnancy. And in fact, a lot of immunosuppression and even biologics, especially the anti-TNF, are safe in pregnancy. However, when you have a pregnant mother, and they are an immunosuppressive therapy, you need to think about the unborn baby. When the babies are born, the baby needs to be avoided from live vaccination for first 6 months of life because of their exposure to the immunosuppression. In terms of mild lupus, every patient goes on hydroxychloroquine, and we have used Dapsone with a lot of success in lupus patients. However, Dr. Khan and Dr. Sayed will probably vouch me on this. More and more people are using tacrolimus and topical steroids and not using Dapsone anymore because of toxicity. Severe lupus means whether you have end organ involvement. So if you have lung involvement, kidney involvement, CNS involvement, or gut involvement, then it's either cyclophosphamide versus rituximab. Rituximab is anti-CD20 monoclonal antibodies. I won't be advocating using rituximab in a setting like Pakistan or India, Sri Lanka, Bangladesh, where the major cause of death in young people is sepsis. So you don't want to use something like rituximab, which will wipe out their immune system completely. However, you don't want them to die with lupus. So if you need to use rituximab, you need to use rituximab with the judicial use. So you do their B and T cell subsets before you start rituximab, and then you make sure that you monitor them significantly, and every fever that patient develop on rituximab needs to be treated as oncological febrile neutropenia. The ultimate aim for the treatment is to